Hi, ladies and gentlemen. Welcome for your presence today with us. It's my pleasure to introduce you the next webinar that we will have today on behalf of the International Society of Gynecological Endocrinology. First of all, I would like to thank all of you of your presence, to all those who were in Florence. We had more than 2,000 participants. It was a fantastic event, and both our speaker, either Professor Rossella Nappi as Professor Peter Chedraui, they were present with us. Now, today, it will be a beautiful session dedicated to one of the most important topics, which is covered also by our society, which is sexuality, women's sexuality. And we have here today Professor Rossella Nappi, who will speak about the effects of sexual counseling in users of hormonal contraception. Rossella Nappi is full professor of OBGYN at the Department of Clinical, Surgical, Diagnostic and Pediatric Science at the University of Brasilia. She's a gynecologist, endocrinologist, and also sexologist. She is permanent member of the advisory board of the International Society of Gynecological Endocrinology and president-elect of the International Menopause Society. Thank you, Rossella. Thank you for being with us. Please, you can share your screen and then you can start with your conference.
Thank you, Andrea, and hi to everybody. It's always a pleasure to be here discussing about one of the topic that I believe you are very much interested in because we don't have so much teaching about sexual medicine in OBGYN residency, etc. And I will focus on some elements of sexual counseling in users of hormonal contraception, especially in the adolescence period, because we really understand with many years of clinical practice that if you start the right way prescribing contraception, then you will go on well with your side effects and the adherence to the method. Whereas sometimes this is not the case if we produce side effects. And I would like to start by setting the ground of our discussion with this study we performed some years ago in collaboration with another university in Turin, Professor Chiara Benedetto. And you see that we interview at that time a large group of healthy women in the age range between 18 and 44 and in the north of Italy, because always remember the cultural setting is very, very important to decode a series of information, especially the one that have to do with sexuality, because social cultural issue, they are very important. But you see from this little graph that women, they are very much aware of the fact that there are side effects of the pill in terms of increasing the risk of developing some symptoms. For example, you see very well the weight gain story is very, very high, and women, they are very much convinced that to gain weight, even though we know that that's not true. In so many women, as up to 80%, as you can see here. But you see that more than 40, around 50% of women, they believe that by taking combined hormonal contraception, we decrease sex drive and we increase vaginal dryness. That is a very important symptom related to genital arousal and therefore poor lubrication and sexual pain. Another interesting example of the point I want to make is this study that was performed in Professor Genazzani's department by Franca Fruzzetti, and she interviewed a very large cohort of women she had in her facilities. And you can see that the discontinuation rate of hormonal contraception over 1 year is quite high. And the majority of the reasons are minor side effects. But you see that minor side effects are more or less exactly the same I have listed in my study before. And poor sexual desire, so an impairment of sexuality, is a very, very high because it takes more or less a percentage that is 1 out of 10 women. So we have 6, they go on, more or less 3, 4, they stop, and 2, they interrupt the assumption of hormonal contraception because of these side effects. And the sexual desire is one of the most important. We analyzed the literature of the impact on hormonal contraception on sexuality. And we did that in our journal, Gynecological Endocrinology, and I thank Peter Chedraui for asking me to write this little manuscript that I entitled 50 Shades of Sex. We realized with my resident Lara Tiranini that we still have several gaps in our understanding of the impact of hormonal contraception on sexuality. And this is a very important point for our discussion today, because if we do not understand very well which is the impact, it's quite difficult to do proper sexual counseling in our patient, and most importantly, proper choices. But I will try to navigate into this with you today. Now, it's important we remember on one end that for some women, hormonal contraception still represents a clear sign of the sexual revolution, and therefore is the best friend of the sexual function and response, because it really gives you the opportunity to separate sexuality from procreation, and giving you the opportunity to experience pleasure and intimacy. But on the other hand, women, they are afraid. As you know, there are so many women reporting hormonophobia. And if you enter social media and other channels in which young women, especially young generation, they talk to each other, you understand that we face a huge challenge, because women, they report and they overstate in some cases sexual side effects of hormonal contraception. And this is partially due probably to the fact that the new generation of women, they do not really understand very, very well the power of separating sexuality from procreation. And therefore, they put their attention really on the side effects. So they believe that this is a chemical procedure, and they link very much sexual dysfunction to mood disorder. In some way, they are also quite right. Why? Because the few longitudinal studies that have been produced in the literature, they put together mood and sexual disorder, hands in hands, and more or less 1 of 10 women, they report both side effects. And this is another point for counseling, because if we want to understand better sexuality, we really need to understand the mood. The next point is really that the majority of the studies that we have out there in the literature, they try to capture the role of changing the hormonal environment in the different domains of the sexual response, not only sexual desire and lubrication, but also orgasm, satisfaction, other dimensions. And they forget that there are many other variables, the psychorelational one, so there is a crucial role of the partner, for example, quality of the relationship, and also duration of the relationship. And this is the reason why it's extremely difficult to draw a clear algorithm, not only for the diagnosis, but also for the management of the so-called hormonal contraception-induced sexual dysfunction. If we look at the literature, just to open the floor to the counseling, One of the best reviews that were performed some years ago focused on the product we had in the past before the introduction of the new natural estrogen on the market. And you see in this systematic review of 36 studies that were conducted until 2011 in more than 13,500 women in ethinyl estradiol pill users, you see that the authors, they were able to demonstrate that the majority of users of combined oral contraceptive report no significant changes in libido. And there were no significant differences in sexual desire in women taking COC in a huge range of ethinyl estradiol pill, from 20 to 35 micrograms. The only category in which sexual drive was decreased, and that was significant, even though not so many studies investigated that aspect, were the one orally containing 15 microgram ethinyl estradiol. So very little dose of ethinyl estradiol may induce a decrease in libido. Then there were all the new age of the natural estradiol containing pill. And the pill that has more evidence on, because has been studied in a multi-center double-blind non-inferiority randomized control trial, is the one containing estradiol valerate and the Energest. And why I'm showing you this study? Because as you can see, in order to try to investigate the importance of the hormonal milieu, we decided with Susan Davis and Johannes Bitzer and other guys working in the field of sexual medicine and OBGYN to compare over time, 6 months, the best association that was known in the literature, ethinyl estradiol containing pill 30 microgram plus levonorgestrel, that, keep in mind, is an androgenic progestogen, so is supposed to be in some way a good friend of the sexual response. And that was the comparator of what? Of a pill that was containing natural estradiol plus an anti-androgenic progestogen. And you can see very clearly from this graph that in spite of this hypothesis that androgenic can be better than anti-androgenic, we found a similar improvement in all domains of the female sexual function index. And that was probably also due to the fact that natural estradiol is different from ethinyl estradiol, and we know very, very well that does not increase so much sex hormone binding globulin. Remember that these women, they were women reporting sexual dysfunction with other COC. And this alludes to the fact that when we switch to a new product, probably we have an improvement, because we had an improvement with both, and there is no detrimental effect of an anti-androgenic progestogen on sexual function when it's prescribed together with estradiol valerate. So we may conclude that from this introductory part that the majority of women, they are doing quite well when they take hormonal contraception, probably any kind, because they are able to adapt both at the central nervous system level in terms of drive, arousal, orgasm, even pain threshold, and other cognitive and behavioral function. We don't have the time to go through all this, but especially about with mood. And they are able to adapt as well to the trophic change that can take place when we are on a combined hormonal contraceptive or even on a progestogen-only pill in terms of engorgement, lubrication, sensitivity, and inflammation. So the majority, they adapt and they found a new balance. Unfortunately, there are some women, they are probably sensitive to this hormonal change that we have into the circulation, thinking about the hypothesis of growing sexual hormone binding globulin, decreasing free testosterone, and we know that this balance depends on the type and dose of estrogen and dose, but most importantly, the category of the progestogen, androgenic, antiandrogenic, and so on. But it's something more probably taking place in this story. And this is the reason why we really need to learn how to counsel our patient. And the first point, it's really to understand the reason why we are prescribing an hormone. Because you should think about that there is many research out there suggesting that if you improve the quality of life of women and you prescribe hormone for achieving extra contraceptive benefits, motivation of women are out there because they are very strong. They want to relieve acne, they want to relieve hirsutism, they want to relieve the pain, etc. And so they achieve a well-being. If they achieve a well-being, that will be extremely powerful in modulating in a positive way all the different dimensions of the sexual response. And you will not report any distress to your physician. Maybe something will happen to your body, but you are so content, you are so happy that things are going well, that you will not perceive that as a distress. It's also true the other way around. If you do not perceive really that it's useful for your health, maybe you are doing just for contraception, but you are not in a stable relationship, you believe you can do without, etc. And most importantly, you develop some kind of side effects, even general side effects from the pill. Think about you increase 2 kilos, okay? You feel bloating or you feel mastodinia, then you will amplify very much what you feel in terms of sexual function and you report to your physician high rate of distress. And we have also to think about that some women, maybe they are not satisfied with the offer we are doing to them, depending on many other aspects. Most importantly, the stage of their life, because for some women, maybe taking the pill is very good when they are adolescent, whereas it's less good when they are over 35 or 40. So we really need to read the need of the women to try to offer the best fix for sexuality in terms of contraception. And to make a long story short, I report that this paper I suggest you to read very carefully because it's the last position statement that we produce working in conjunction with the European Society of Sexual Medicine in order to guide the clinician on the best choice for women developing some kind of sexual dysfunction under contraception. And we point to the importance of decoding the individual experience of women and on the fact that we cannot produce any final conclusion on the basis of the literature we have. This was immediately before COVID, and as you know very well, we did not produce so much research on this topic afterwards. And here you see the algorithm that we produce together with so many sexologists and experts in sexual medicine. First of all, of course, what they suggest? They suggest that we really need to perform a baseline psychosexual relational assessment. So it's not so easy in a short period of time to collect all the relevant information, but we should learn, and I will show you some screener, for example. It's obvious that we cannot prescribe whatever we want. We really need to stick to the medical eligibility criteria. And we have really to point to our patient on some potential side effects. So we really need to acknowledge with our patient, we do not have to deny that for some women, this may be a side effect, because out there in the literature, it's clear that in some setting, we try to avoid a discussion on sexual side effects in order to avoid the nocebo effect, because we know that if you anticipate some side effects, women then will develop, okay? So there is a nocebo effect. But unfortunately, if you deny that, women, they don't feel that you perceive their need, they feel you are trivialized their need, and therefore this is a boomerang from a sexual medicine point of view. So really the authors say you really need to support a patient-centered decision that take into account this issue of sexual medicine. Of course, you can administer combined estrogen progestogen contraception, and we know that this is usually one of the first offer we do in women without any contraindication, especially in the adolescent setting, because you can start by yourself, you can stop by yourself, and however, in some countries, long-acting progestogen only choices, they are also welcome, but this is not the case of my experience in Italy. But in any way, you see that you start with what is you believe is best for the woman and what the woman prefers. The author suggests to review usually in 3 months. We know that sometimes it's not so easy to see patient in the clinical setting in 3 months, but we may establish a contact with our patient by WhatsApp or by the email in order to make a list of the good point and the bad point of the hormonal contraception. And so you do a follow-up, especially in terms of 2 different symptoms. The one we said at the beginning, reduced desire or reduced lubrication. Some women, they report symptoms that are very similar to VVA. And if they report similar symptoms to VVA, we may do some action. But you see that there is a very low level of evidence. Evidence 2, 3, no more. And this is true both for VVA, reduced lubrication, and for reduced desire. What you do in the first place, of course, you can stop taking hormonal form of contraception. This can be an option, but the level of evidence is very, very low. Switch from oral to non-oral form of hormonal contraception, even removing the estrogen component, such as you can do in an IUD medicated with levonorgestrel, or implants, or even there are some data out there prescribing the vaginal ring, because by prescribing hormones, even though it's a very low dose, 15 microgram, but directly in the vagina, you may increase the perception of lubrication in some patients, not in all. And then you can switch to other oral form of contraception with higher ethinylestradiol doses, because I told you that the only evidence we have is that 15 microgram are negative for both desire and even vaginal trophism in other studies. When it comes to reduced desire, again, switch to non-hormonal form, switch from oral to non-oral, and switch to other oral form of contraception. And we included also estradiol, natural containing pill, because of the less impact on sex hormone binding globulin and the study I showed you before. But you see, the evidence is good only when you are on estradiol valerate dienogest or ethinylestradiol levonorgestrel, because there is a randomized control trial. And then you do a follow-up. But even if you do so, you have to remember that there is a personal metabolization, a personal sensitivity to receptor, and different women, they have different hormone levels. depending on many other variables that have to do with the gynecological endocrinology worlds. Think about thyroid function, think about insulin. They may influence the ability of the hormone to target into the tissue. And so, depending on what I told you before, hormone type, dose, activity, and the reason why we are prescribing the pill, and also the other interpersonal factor, we cannot offer a recipe that is good for everyone. We have to think on one end that we really need to rule out, for example, clear condition such as vestibulodynia or the new entity we name vulvodynia related to endocrine dysfunction, because these are conditions we really need to treat because they may develop very fast following our prescription of a COC, probably because these women, according to some data, they report estrogen and androgen receptor polymorphism. And also, we don't have so many data on that, but we have to really think about endocrinology, metabolomics, other mechanisms, they occur within the tissue, because nowadays we know that the genitals, they are able to produce their own steroids. So we really need to go and try to do some attempt to relieve the symptoms. And I share with you my basic principle in clinical practice. And in the discussion, we will see if you will agree with me that we have always to consider these two big boxes, the estrogenic side effects and the progestogenic side effects of a pill. And this is true for many different side effects. We know from the literature that when you have a dominance of the estrogen, for example, there is some data suggesting that you may develop loss of libido. But this loss of libido is not associated with depression. So if we use a depressive screener or if we do some question to understand depression in our patient, we can achieve some good information. Whereas if we have a concomitant loss of libido with depression, it means that you have a dominance of progestogen. And this is also very true when you have vaginal dryness. And this may occur because the progestogen is strong or because you are offering too low dose of ethinyl estradiol, and so there is a dominance of the progestogenic effect. And so we can play with all the product we have out there in order to find the good right fix to our patient. This is the screener I suggest you to use that has been developed for hypoactive sexual desire disorder. And you really need to ask a very simple question. First of all, you really need to avoid overstatement. And so you really need to understand if the woman developed the symptom following your prescription, because you really need to have to ask what it was before and what is nowadays. And most importantly, if the woman is bothered, because some women, they say to you, I have low desire, but then they are able to have a satisfactory sexual relationship anyway. So, meaning that it's not so relevant, and maybe if they go on, they will feel better. What you have to really recognize, if there is some other sexual issue going on, such as the pain, because if you feel the pain due to low lubrication, as probably Peter will explain you very well, then that will be another story, because you may develop the vestibulodynia I showed you before, or you perceive that your arousal, genital arousal, is lower. And therefore, we really need to do something about that. And this is the issue of dyspareunia, something we really need to recognize. But it's also important to conclude to collect information on the cues, for example, that help the women to light desire in their body. Because there are plenty of data out there suggesting that there are different phenotype of patient in front of ourselves. People, they really need organic endocrine factors to light up their own sexuality. And these are under the control of hormones. And we know that from basic research that explicit erotic or visual proximity cues, they may be modulated by hormones. But there are some women, they engage in sexuality due to romantic, implicit, other factors, emotional, bonding, affection. And this is the topic that is much more difficult, but we really need to enter into this discussion with our patient with very simple questions regarding the level of affection, affiliation to the partner, what is the stimuli. They are very important. Having a dinner in a nice setting together, or for example, seeing your partner, etc., naked, other even stronger pornographic, for example, stimuli, etc. It's not so easy, but we really need to capture this. And I would like to conclude with this beautiful cartoon. I like it very much because this is a new concept that we really need to develop in our daily practice. And I endorse this idea of the so-called sexual acceptability of contraception. We don't have to talk about sexual side effects only. We really need to consider uh, the impact on sexual well-being, but not only on the individual or we may say micro level, but also on the level of the relationship and on the macro level. Only if we consider the kind of relationship that the woman has, we can really understand why some women they overemphasize side effects and why other women they underestimate the side effects, and also the concept of pleasure, because I believe we should learn to speak to our patient not only about sexual function, but about sexual pleasure. What does it mean for yourself and why contraception is so important for your own sexuality, first of all, in terms of building up an healthy relationship. I believe that sexual acceptability is a concept that is not only relevant in our discussion with patients on sexual side effects, but also on gender equality of our patient. And with this, I thank you very, very much, and I'm ready to take your question.
Thank you very much, Rossella. In fact, the questions are already rising. I remind everybody that you have in your screen the place where you can write your question, and I will introduce later on the question to our speaker. And now we will move on to the next speakers. And please, if you can change me the slide. Yes, now I would like, first of all, I would like to remind you that the next event of our webinar will be Wednesday, 12th of June, always at 3 o'clock Central European Time, and will be another very important chapter where we have added a lot of new attention also in Florence now, and it will be with Professor Angelica Linden-Hirschberg and Professor Basil Tarrazis on polycystic ovary syndrome, importance of guidelines. This will be the next webinar. And then now we will go to Professor Peter Chedraui, who will have his own presentation. And Peter Chedraui is past president of the Ecuadorian Menopause Society, member of several international scientific society boards, of which he has served 2 full periods for the International Menopause Society, 2 for the European Menopause and Andropause Society, and 2 for our beautiful International Society of Gynecological Endocrinology. He is currently editor-in-chief of Gynecological Endocrinology, our official journal, and associate editor for Climateric, the official journal of the International Menopause Society. Please, Peter, you have the microphone, you can share your screen, and you can make your presentation on sexuality in midlife women.
Good morning, Andrea. Good morning, everybody. Thank you for the introduction. I'm very pleased to be here this morning and have been in Italy with all the members of ISGE, and very happy to be now part of the executive committee now. Okay, I've been asked today to speak about the sexuality of women during their female midlife, during the transition of the menopause, which is a very important phase for women because there are many changes, biocycle and social changes that affect women from a sexual point of view. It is very important to mention that sexuality and sexual health are important aspects of human health and well-being. And sexuality as per se for human and for women, especially during the menopausal transition, is very complex. As Rossella has shown on her slides, there can't be a total recipe or algorithm to analyze the different aspects of sexuality, because everything is there's an interplay between not only the hormones, the biochemistry, and the sexual part, and the partners. But one fact that is true is that as women age, their female reproductive capacity, sexual activity, and satisfaction decreases. It's difficult to establish, the real incidence or prevalence of female sexual dysfunction, which goes around between 25 and 43% of the general population, because many studies are not population based. So we draw these from menopause clinics, or especially for menopausal transition, and these we usually rely on selection bias and selection of random samples. So it's very difficult to establish. But the climacteric, the menopausal transition, increases the risk of sexual dysfunction almost threefold, and which is more evident during the ages of 52 and 65 years. Not only related to hormones, as we will see, but related to organic parts, which is very important. And the time since the menopausal transition is very important. As you see in this slide, women who are in the early menopausal transition present lower prevalence of sexual dysfunction as compared to those in the late menopausal transition. Self-reporting, the low sexual desire in menopause is also associated with, as you see, now we know that women who are surgically menopaused, which is something that is very hot topic now. We are writing some papers now related to hysterectomy and surgical menopause. Even women who have hysterectomy also have lower or low sexual desires. You compare here women who have had surgical menopause compared to the natural menopause, the incidence or the prevalence of low sexual desire is higher, even in younger women as compared to women who are older. Low estrogen is associated with increased prevalence of sexual problems. As we can see here, very important, as the levels of estradiol decrease below 50 picograms ml, you see that the prevalence of vaginal dryness, bothered by problem, dyspareunia, the intensity of this, pain with penetration and burning are higher as compared to women who have higher levels of estradiol. So as you see, a component of women's menopausal transition, as the levels of estrogen start decreasing progressively, there will be an increase directly proportional of the prevalence of sexual problems. We cannot underestimate the role of androgens also, which is also a hot topic. Yet we know that androgens command sexual function also in women, and as androgens decrease, which is not something that is very evident, but and difficult to correlate with the levels of estradiol, there is a decrease in libido, androgens give women the motivation, and this we decrease androgens, fatigue increases, and there are mood changes. And this has been evidenced because when we administrate estrogen and androgens, or androgen versus estrogen, the placebo show an improvement in mood states and the general well-being. There is a link, and we will show some slides, between depressive symptoms and sexual function. This is very important to know that as estrogen levels decrease, there's an increase in sleep problems, vasomotor symptoms, which also cause a disturbance in mood changes, and this has an effect over sexual function. Sexual dysfunction is evident, as we said already, in the perimenopause, the phase of transition to the menopause. Once the menopause is established, we have the postmenopausal phase, in which not only hormonal, there is the impact of decreased hormone, but also the aging process per se. As Rossella said, we have problems of lubrication, problems of vaginal atrophia, which is now known as the genital syndrome of urogenital syndrome of the menopause. There's a decrease of loss of lubrication. There is less participation in response to stimulus in women who are transiting the menopause. The frequency and duration and intensity of orgasm also decreases. Related to androgens, also, we have the absence of sexual fantasies and less gratification, and in general, a decrease in sexual interest and a decline of sexual activity. Here we can see, because this is general, as you can see, female sexual dysfunction has a different interplay of physiological aspects, psychological aspects, interpersonal relationships, and social cultural influences, which are very, very, very important. This is a general algorithm or scheme for general female sexual dysfunction, but it is applicable to women who are transiting the menopausal transition, because, for instance, women who are transiting the menopausal transition in psychological aspects, we have depression and anxiety, which increases with the decrease of estradiol levels. So there you see that the psychological part is very important and plays a pivotal role in female sexual dysfunction. Is the sexuality, or there is an increase of low sexual desire, there is also an impact on quality of life. As you can see in this slide, there is a low physical satisfaction, 4 times higher, 3.5 higher of low emotional satisfaction, and there is a low general happiness in general of women who are transiting the menopausal transition, which is related to levels of estradiol, as we know. In terms of the epidemiology of female sexual dysfunction, as we mentioned, the prevalence calculated from samples drawn from the general population are not very easy to perform. Performing a population-based study is not so easy in terms of logistics. So we generally rely on random samples, and if these samples are provided by a menopausal clinic, which basically attend these type of women, it's difficult to establish a prevalence. All studies are based by clinical samples or volunteers. We have done a lot of this research in Latin America through our network of research of the climacteric in Latin America. Preparing the prevalence calculations are important to understand the impact of female sexual dysfunction in the community, and studies have been performed in clinical context. Is not that increased. So there's a wide variation in samples size observed in majority of studies. This is a very nice study we performed many years with Professor Blumel and our network of research for the climacteric in Latin America, which this Friday we have a meeting in Cusco, Peru, for celebrating the 20 years of having created or founded the network, the Red Link, which has made more than 35 papers throughout these 20 years, congregating a group of collaborators. As you see, we have so many people who have been working in Latin America, and this paper has been cited and in an editorial in Menopause, which we believe is a very important study, which at this time when we performed this study, we gave some insights, very important insights. And this is 2009 research project, which is the Red Link 3 study. Now we're up to the 13th one that we're going to initiate on something very important, which is workplace and menopause, which I think is a very hot topic, and you will be hearing about us in the near future and through our publications. In this study, 7,243 women were surveyed throughout Latin America, in which we can see that a fourth were sexually inactive. These women who were sexually inactive were older, significantly older, had less education, and were postmenopausal in a higher rate than women who were sexually active, who also used a less percentage of hormone therapy compared to women who were sexually active. And as you can see, the percentage of partner with sexual dysfunction is lower in sexually active women as compared to the ones who are sexually active. The rates, this was performed with a female sexual function index, which is a questionnaire of 19 items, exploring 6 domains of sexuality, which you all know. And this gives a score which tells you the percentage of women who have possibly female sexual dysfunction. This slide is to demonstrate the variation of partners that have sexual dysfunction comparing, different countries. For example, there's lower in Cartagena, Colombia, compared to Bolivia, which has a higher rate of partners with sexual dysfunction. And this is the rate of the sexual dysfunction across the different countries that participated. And you can see that as high as in Quito, Ecuador, you have almost 98.5% of women who have sexual dysfunction according to the cutoff value of the female sexual dysfunction, compared to Chile, to Cartagena, 21%, and then globally, 56.8% of these women who are mid-age, 40 to 59, have female sexual dysfunction according to the FSFI. We performed also a study. In this study, basically, and this is the important point, among the sexually active women, we performed logistic regression and determined in order of importance, which is really the most important or pivotal risk factor, and we found it is bad lubrication. And we also like to highlight the importance of the sexual failure of a partner. As Rossella said, very important, the the relationships with the partner to have a role in this time of life of women is very important, the partner also and the relationship they have. But the research that we performed in 2009, almost 15 years back, we determined the importance of bad lubrication, among other factors, as you can see here, being married, women who are more educated and go to private healthcare system have a decreased risk of sexual dysfunction. And using, for example, a hormone therapy, in this case, for example, we found that it increases the risk of sexual dysfunction, which basically we discussed this, that maybe these women have more symptoms and have other type of problems which need to be sorted out. In another study, 846 women aged 40 to 60, this study of TOMIC, which is a classical one, we found also that age, education, alcohol consumption, vaginal dryness, as we said, bad lubrication, are factors related to a lower desire for their partner, and factors related to lower sexual satisfaction is age and vaginal dryness. This is a study from Professor Blumen, performing research among 534 middle-aged women, and as you see, as years pass, the problems of desire, arousal, orgasmic problems increase exponentially with age from 40 to 65 years. Their multivariate analysis determined that use of hormone therapy decreased the risk of sexual dysfunction, and their self-perception of normal health also decreases. And as you see, the factors that increase risk of female sexual dysfunction, we have hysterectomy, the age, the presence of being postmenopausal, and the component of the male is also very important. And see the level of education also decreases the risk of female sexual dysfunction. We performed that also with the Lawman criteria in 385 climateric women. As you see, as the prevalence of sexual dysfunction increases exponentially with age, with a mean of 78.4% and 92.3% among those who are 60 to 65. And our factors found basically those related to the partnership, the partner, and the use of female antidepressant, and those that decreased, as you see, schooling again, education, intercourse more than 4 per month it decreases the risk of sexual dysfunction. That's why there's the importance of maintaining sexuality after the menopause is very important. Of course, once we solve, orgonic and estrogenic, the estradiol and the vaginal health, sexual intercourse will maintain a decrease of sexual dysfunction. We also did something from in Ecuador, in which we found that, again, the masculine component in our cohort was very important. Low schooling, and the age of the partner were very important. Personal factors, age, menopausal status, use of increased the risk of female sexual dysfunction, and those decreasing the use of hormone therapy. Using a specific quality of life questionnaire for the menopause at Toronto University, there are some items of the 29 items composing the questionnaire. 4 domains: vasomotor, psychosocial, physical, and sexual. There are 2 items. Higher scores is more negatively affected the quality of life. More than 50% of these Ecuadorian women, 325 that we surveyed, had scores of sexual domain above the calculated median, which was 4.9. Women who had problems with metabolic problems were 2 times more at risk of having sexual domain scores above the median. The evaluation of women who have the evaluation of sexuality of women who transit the menopausal transition, we use the FSFI, which has 19 items, which is very long, and from a practical point of view, during routine clinic and performing research, sometimes we have to do the routine clinic, observing women, for their basic gynecological workup, and completing a questionnaire. It's very difficult to do some research with these type of women. But we also validated in Ecuador the 6-item sexual function, which has 1 item per domain, and it performs a rapid assessment of sexuality in any population you want to study. In this case, a population of women mid-aged, Ecuadorian. And you see, these are the 6 questions, which is what has validated, and we have that adapted into Spanish. And it assesses in the past 4 weeks the sexuality of the women who are being surveyed. In this case, we did a nationwide. In Ecuador, 904 women were surveyed with a short item of the FSI, and we found correlations with sexuality, history of abuse, sedentarism, the intensity of hot flashes. In this study, we correlate how vasomotor symptoms affect quality of life and also affect the relationship and sexuality. Also, as you see, there is a positive correlation between the frequency of coital frequency and the score. The higher scores indicate better sexuality, lower scores indicate a worse sexuality. We also performed this study evaluation among women from Hawaii, in which we found relations with menopausal, with partner age, and again, coital frequency is positively correlated with a better sexual function. Glycemia, as we already mentioned, we have correlated also with sexual complaints, increased sexual complaints. And Here, as we see in this study, we also correlated the associated depressed mood and sexual function using different type of logistic regression model, in which we found that women who are more depressed present a higher rate of sexual dysfunction, which again establishes the important correlation between mood and sexuality. In this other study among only Peruvian women, we also found correlations within the intensity of scores of the urogenital, which highlights the importance of good vaginal health with good sexuality. And again, we have the partner component as always. Hysterectomy has also been correlated to sexual function, not very easily established, but now we know that women who have surgical menopause, and inclusively, many studies are now indicating even those that have not only bilateral oophorectomy, but also hysterectomy, have lower sexual function compared to women who have menopause, who are naturally menopause. This is just to compare in women who are sexually active in one study and demonstrating that the ethnic part, as you compare women who are Afro, lower scores compared to those who are mestizian, and compare in lubrication, we have better scores in comparison to women who are just mestizo. This is a study from Álvaro Monterrosa and his group. And so just to wrap it up, clinical history for the assessment of sexual dysfunction should include a specific description of the causes of sexual dysfunction and analysis of the sexual functioning. As you see, there are screening tools that are very easy to apply. The moment of initiation and progression, the theory that patients might have about the cause of the sexual dysfunction. Sometimes they self-report and self-describe what the problem really is, the precipitating factors, what effect or impact has this sexual dysfunction over their personal relationships, prior treatments and outcomes that they have received, hopes and purposes of treatment, understanding the behavior and the physiology of sexual behavior is also important. And also explore the different myths and misleading concepts related to this. Obstacles for routine sexual history taking in our gynecological consultation is very difficult to explore profoundly sexuality among mid-aged women, because this takes time. There are time constraints with the physician in outpatient clinics. It's very difficult to especially if you're exploring gynecological routine issues and not in a specific menopausal scenario. Discomfort about the topic, limited training in female sexual functioning, as Rossella said already. This is not part of the pensum or the subjects that the residents in OBG receive in training, specifically in sexuality or endocrine issues or diseases, and lack of treatment. So, conclusion. Sexual dysfunction in middle-aged women is a multifactorial and may impair quality of life. In Latin America, the prevalence is high, in which, as we've seen through my slides and evidence-based, the male component plays an important role. More epidemiological data should be carried out to confirm this and explore more social aspects, especially in Latin America, and where cultural and transcultural issues and aspects are very important. The management should be preferably preventive and directed towards biopsychosocial aspects. If we know that women transiting the menopausal transition are decreasing their levels of estradiol, maybe early estrogen therapy or menopause hormone therapy could be very important. I thank you very much for your time, and
thank you.
Thank you, Andrea, for letting me
thank you
share my humble slides to the people.
Thank you very much, Peter. We are now moving to the general discussion, and then I will go on general questions that we have received, a series of them. Or like, first of all, I want to start with one raised by Fred Naftorin. First of all, Fred, I thank you very much for being with us. As always, you are a great supporter of ISGE and our webinar strategies. And he thanks both of speakers. And he made that comment and the question. This is a difficult area for both researcher and women to study without confound. Is this an area for the application of deep learning strategies? Please, Rossella, do you want to answer?
Fred, ciao. I think this is a great question as usual. And I really believe that this will be the future. Only by collecting all the different biopsychosocial determinants that we know that can affect the human sexual response, both in the biological, psychological, and relationship domain, even though maybe will not capture the individual experience, but at least will help us to understand different phenotypes of women and the way they may react to some hormonal manipulation. Because there are some women, they are so fine on hormonal contraception since so many years, and other that as soon as they take it one, it's a disaster. So it's very, very difficult to guide the clinical practice, and we should do a multicultural cohort study on sexuality. It identified, according to the literature, which one are the factors that show a real evidence, and to try to figure out how we can analyze that data with artificial intelligence, machine learning, other technique that can produce some good guidance.
I'd like to add in this aspect something
Please.
that Rossella just said right now. I believe personally, in my personal experience, and I think that this is a model that may be studied. I think that there are different type of phenotypes of women regarding sexuality. Definitely. I know women who are postmenopausal and they're actively because they say that they feel here, this is what commands. And their relationship with their husband is also very important. So there are also phenotypes of men also in sexuality. We have men who are not so, into it, and there are others that are less. So I think that the combination of this is very important. And how to sort it out is not very easy, because how do we explore the different phenotypes? There must be tools. We have to maybe research this transculturally, as Rossella says, and this is very interesting to perform research on it.
Thank you, Peter. And then now we move to another question that is Jose Alberto Hernandez Bueno from Mexico, who tell good afternoon to both of you and ask Rossella, what is your experience with drospirenone-only contraception and women's sexuality? In the same line, we have also the question of Oranite Goldratt, who asked what about progesterone-only pill like drospirenone 3 milligram and other POP?
Salvatore, fantastic to have you here. And this is a very good point. Probably this year you missed the gynecological endocrinology in Florence, because I didn't see you, because my research fellow, Lara Tiranini, report a study that we are finalizing. This is the reason why I didn't show specific data, because she showed at the meeting only the follow-up, the brief follow-up on 6 months, but I believe we need longer, in which we test 3 different pills. We show only the data of drospirenone only against the ethinyl estradiol containing pill, but now we are finalizing also the data with estetrol, because that was a good way to use the same progestogen in 3 different endocrine settings. The one in which you have your estrogen yourself, because you have only the POP, and the other one with the 2 options. And what we found, that it's really true what we have in the literature, that 10% of women, they really improve, 10% they really decrease, and the majority of them, 80%, they go on reporting their own sexuality. So you do not change so much, you do not decrease so much, and you do not improve so much. But it's always something that is an individual stuff. But all the group the percentage is more or less the same. So it's not detrimental if this is what you want to know, because as you know, in the literature, there are signals that when you use the POP, you have a detrimental effect on sexuality. I don't think this is the case. It depends if your body feels that there is a dominance of the progestogen. But if your body does not feel that, you don't have a detrimental effect because you have enough estrogen within the tissue, either the genital or the brain or whatever, that will protect you from the side effects. This is really my feeling. And as more I study this topic, more I believe it's a question of how women sense the balance of estrogen and progestogen, as it's not a question of progestogen only pill or levo or whatever. It's really a balance.
Peter, you mentioned in your slide about sexual dysfunction and middle age in Latin American women. That from some slides, it's clear that hyperglycemia, depressed mood, and in a certain sense also that obesity can be negatively affected. Obesity is an area which is strongly increasing now in our recent years. Do you want to make a comment between the impact of obesity and metabolic syndrome and sexuality?
Yes. We just published with Rossella an editorial on obesity and sexuality, and I missed putting a slide on this to update it. But yes, I agree. This is a very important topic now in the menopausal transition as women increase their weight. There are studies that indicate that women affected their quality of life and also their sexuality. And this is something that we're exploring. We're also, we have a paper on the review about menopause and obesity, which is a very important topic. So yes, the metabolic syndrome and the increase of weight in women and it causes also a decrease of sexuality. But again, there is also we can't say it's totally, because there are women also that maybe do not decrease. So I think that it's a question of the phenotype of women. As you know, there might be women who have increased weight, but their phenotype does not have to do nothing with the metabolic issues. Okay, I think that maybe Rossella can add a bit more on that.
And I would like also to put a question, Rossella, before that you answer, I would like to add you something. Do you believe that overweight, obesity, metabolic syndrome of the woman have impact on sexuality because it can have also impact on male sexuality?
Yeah, it could also be that. So you see, once again, there's an interplay of various factors that we can't have an algorithm so clear, but we know that we have to be alert and give the management has to be tailored per patient or per woman or couple. That's what I think that it's the best way. But there are papers talking about sexuality and obesity in the menopausal transition.
Rossella?
I revised the literature on postmenopause very recently. And of course, it's biologically plausible that obesity may affect a different domain of the sexual response throughout different kind of mechanism, endocrine mechanism, but very interestingly, the inflammation, low-grade inflammation, and endothelial dysfunction at the genital level. But I have to tell you that data are scant, not well controlled. We have, population studied, but not so large. And the study that was recently published in North America said that there is an impact, but the psychorelational variable seem to be more important than the biological aspects and the endocrine aspects. And therefore, you see, it's always the same story. If we want to study the impact of a medical condition, like, for example, taking hormones or being obese, we have always to consider a full range of aspects. And this is the reason why it's so difficult. But we should address in the OBGYN practice, not because we have to become sexologists, but because we have to teach our resident how to break the ice, how to raise the 2-3 good question. Because if you don't have a training, you're shy, you're not able to investigate better, and you miss the opportunity to send to somebody else that is much more expert in the field of sexual medicine.
Thank you. And there is a question now, where can we, it is from Ola Semeshko, where can we order testosterone cream?
Unfortunately, here in
think it's
Ecuador, we do
forbidden.
not have, we don't have here in Latin America, it's not so easy to get product. Here in Ecuador, we don't have the cream of testosterone. So I can't answer where you can find it in other parts of the world, but I don't know if you want to add something, Rossella.
You know, testosterone cream, you should prepare compounded. In some countries, we have also this vegetable extract. They have a testosterone activity. For example, the testosterone derived from Damiana sinensis. And, you know, it's really unsafe because the only place in which we can buy testosterone is Australia, as far as I know. And if you prepare compounded in the pharmacy, you cannot control, for example, how much cream the patient is using, etc., etc., etc. And so we really need to perform a better study to convince the authority that testosterone is useful for some phenotype of women, maybe not for everybody. And this is the reason why, according to the guideline, when we use a systemic testosterone therapy, we say following 6 months, if it's ineffective, it's because it's not enough. You should look at other variables and you should not go on. I have a patient that when they are on testosterone, they are feeling much better and they have a better sexuality. Other, they have absolutely no change. And on the genital is more or less the same. You increase the trophism, but sometimes you do not increase the arousal, because if the arousal problem is related to something different, there is not testosterone that can do some good to, let's say, a bad relationship or other intrapersonal or interpersonal aspects.
Now we have now an interesting question, which is which is raised to both each one of you who have this possible answer. The question is, what about the changes in sexuality in women or in homosexual relationship and sexual dysfunction?
If I may start, I have to tell you, please go on the website, if free access, Journal Sexual Medicine. We revise the literature according to the couple, and we were able to observe that there are few data on lesbian sexuality, especially in older women. We don't know so much, for example, about the impact of GSM on their sexuality, thinking about the role of the genitals, that it's even stronger in comparison to heterosexual women, in which the vaginal canal seems to be more important. And so we should perform this kind of study. But, you know, if it's so difficult to uncover the topic of sexuality, difficult to recruit for clinical studies, well-controlled studies, these women. Probably younger generation, they are doing better, and we have some data out there. But as you know, they don't take so many hormones, so it's very difficult to see them in OBGYN, gynecological endocrinology setting. And we see some of them with PCOS. And I am under the impression that when you use anti-androgenic treatment for these women, you touch more their libido than in other patient. But I don't have a proper study to be sure I'm telling you the truth. It's just my clinical impression on a small group of women. We should do multicentric study to increase the power and also to explore those settings in which homosexuality is much more accepted in comparison to my country, in which still may be a problem. Okay.
I think I would like,
we
we would like
don't.
to add something before Peter. No, also in my experience, I have some homosexual patients who are coming to us, but the general referral of important changes associated to sexual dysfunction in their relationship seems to be less present in comparison to women who have to an heterosexual relationship with a fixed partner. I think the loving aspect of the homosexual relation can be more continuously present in the relationship in the comparison of the heterosexual couple. This was my impression, but just to mention.
Yeah, we don't have also a lot of data. We don't have data on this, but I once, and in the 20 years I've been transiting over Latin America, performing these red link studies with Professor Blumen. One time we wanted to perform a study like this over Latin America, but as Rossella said, there are barriers to do this type of investigation. Maybe now it could be easier, and we could gather some multicentric information. But the perception is, and I do agree with this, and listening to Professor Hidalgo, Professor Blumen, the impression is that women who transit the menopause, the menopausal transition and the postmenopause, there seems to be a perception that there is an increase in homosexual relationships with other women because they have problems with their husband, and this seems to have a better binding at this stage of women that increases their tendency to have different tendencies, sexual tendencies. And the other perception that I've also observed in Latin American countries also is that older women start preferring younger men, because as you saw, the component of sexual dysfunction is also the male component. So many women in Latin America, right, now prefer younger partners.
Then we have a question from Sofia Cordova for you, Peter.
Yeah.
She's greetings from Guatemala, and she asked, are there any website or places to find more information and research on Latin American women?
I think that this should be the best way, and this is why, and Rossella will say yes to this because we are binded in IMS. Now IMS has the CAMS sections, and these websites, each CAMS member of which they're from Ecuador, from Colombia, I think that this would be very important to in the next session of CAMS indicate that these websites also have sections for women who can read in Spanish or English, whatever, to know more information about the menopause, especially among Latin American women. But it's specific sites. We would have to Google it and find some place that there must be information. But personally, I think the best way is to go IMS, or International Menopause Society.
Thank you. And then now Herian Gilei, I have she write to you, Rossella, dear Professor Rossella. And there is an interesting question for the president-elect of the International Menopause Society. In is a regular orgasm in women helps to have more calm menopausal symptoms, especially of flushes? Take care of the answer. Take care of the answer.
Yeah, I take care of the answer. And what I know that, as you know, there are some people they are quite compulsive on orgasm with masturbation to relieve anxiety. And this can be considered also, if it's too exaggerated, a disorder, okay? Because it polarizes your life. I don't think there is a signal in the literature that link the frequency of orgasm and the frequency of sexual intercourse without flashes. So probably we should produce some data, but for sure, the orgasm help very much our well-being in the brain and therefore can do some good. We can design a study together, my dear friend.
I totally agree with you. And now another question also for Oranit Goldratt. And she's, what do you suggest in a case of a young woman with breast cancer under aromatase inhibitor with local treatment with hyaluronic acid and loss of libido without flashes, etc.? Peter?
That's a difficult one, but yes, a young woman who has breast cancer is under aromatase treatment definitely has a problem. But again, local there you can also use local treatment. It's a matter of discussion and debate. You know, currently always using any kind of estrogen. Women don't want to use anything, but alternatives like hyaluronic acid and good lubrication. But also here in the brain is the most important thing. A supportive partner of a woman who has this type of problem, not only perimenopausal, but premenopausal worse, is very important. The support and the loving that the partner has for the woman who's affected by this problem is very, very important. I don't know, Rossella, if you want to add something.
Okay. You said already what is needed. I mean, unfortunately, until we will not have the possibility to treat our patient with a specific drug to relieve a vasomotor symptom, for example, NK3 receptor antagonist. And, we really need to discuss for VVA, GSM with the oncologist the possibility to use hormones locally at least, or we have to wait until they feel better and they complete the aromatase inhibitors cycle of therapy. At the present moment, we don't have so many weapons in our hands.
Thank you. And then there is now a question also from Oranita Golda that I would like to answer because we have a special experience on that. What about women with ovariectomy but treated with estrogen and DHEA? As you know, we have a large experience of DHEA therapy, and we have found that the addition of DHEA to estradiol treatment in ovariectomized and hysterectomized women, this maintain or do not have any deleterious effect on sexuality, and we had no complaint. But in some cases, we had a recovery of women who start having a better sensation. I would like to have a comment from Rossella and Peter.
I agree. I agree with you, Professor. There are a lot of studies, although, there are still debate on the use of DHEA, but anything is valid if you want to have an alternative treatment, and especially in these women, as you saw in the slides, and we are now under the track that surgical women and even now hysterectomized plus bilateral oophorectomy. We're finalizing a paper with Professor Blumen, which we published, in which we found that not only oophorectomized women, but those who had hysterectomy plus bilateral oophorectomy compared to natural menopausal women have increased sexual dysfunction compared to those. And we're talking about data of 5,000 women or something like that. Okay.
Thank you. And now, Rossella, do you want to add something on this point?
No,
and then
I think DHEA is an individual treatment that is not recognized by the guideline, as you know very well. Last one, Andrea, because unfortunately I have to teach to my students at 6.
One is a general comment. I wanted to read you a question, which I think a comment is very important to all of us. It is in Spanish. It tell the need. Do you believe that it will be the education in sexuality have to be added in the program of training gynecology and obstetrics? And the person is Anna Toscano. I think, Anna, this today, the webinar on sexuality is just on that line. we strongly believe that sexuality have to be taught during the education and formation in our schools to become a good obstetrician and gynecologist too. And I will have on that point to have final comment with started with Rossella, then we had Peter, then Rossella first, you have to go to your students, and then after.
I told you, we have to study to learn to recognize. And of course, we really need to work in a multidisciplinary team because OBGYN cannot do all the job. And we really need other experts, even pelvic floor specialists, psychologists, sexologists, whatever is needed to improve the general domain of sexuality that has a lot to do with culture, feeling, emotion, etc. And also the health of the partner. So we need a urologist, andrologist on board to help us. So bye-bye, because I have another teaching class.
Thank
Ciao.
you, Rossella. And then Peter,
Ciao.
can you give your comment on that point?
Yes, yeah. I think that, you know, incorporating directly into the program like a subject that you have to have a grade on and pass, it could be difficult because, you know, the curriculum, the Maya curricular, what we call, I don't know how the curriculum of learning, it doesn't put the need. They put the needs on what each country has, and obstetrics is basically based on OBG and gynecological. But I think that in this general practitioners or when they're doing the residency on OBG, there could be like courses, and this is where ISGE could also help, right? Making educational courses for residents in certain subjects that are not covered as normal subjects in their residency. You see, so this is very practical. This could be a good field of work educating in sexuality, in menopausal and endocrine aspects of female, like gynecological endocrinology. So I think that's what we should be. That's what we're going to work in, Andrea. We have a lot of work to do with Tommaso.
Then thank you very much to all of you for being with us today. I think it was a fantastic webinar on an important area of our daily life for us and for our patients. And sometimes I remind that the gynecologist is the first person to whom the woman can put question about the topic. Then we need also that the gynecologists are ready to hear and also ready to offer informed answer to their patient. And with that in mind, I thank all of you for being with us. I remind you that we will have a next webinar, next one, which will be devoted to polycystic ovary syndrome with Basil Terlatzis and Angelica Linden Hirschberg. And then now I thank all of you for being with us. And thank you again on behalf of the International Society of Gynecological Endocrinology, who promote all our attention to the fantastic world of women health and women life, but not only for women, but also for human gender, for the couple, for all of us, and for our children. Thank you very much for being with us, and we will meet very soon.
Ciao, Andrea. Ci vediamo.
Bye.
Bye. Take care.